that decision every time that they're going to take an RA treatment, right? Every injection, every tablet, everything like that. It's got to be something that you're comfortable with doing.
Hello, everyone, and welcome back to You Create's podcast, Many Different Birds, broadcasting on CJSW Radio, where we'll hear authentic stories from special guests from all backgrounds and bridge the gap between non-Indigenous and Indigenous communities, with a special focus on the Canadian healthcare system. We want to open up the floor to honest discussions and get a deeper insight into how we can improve our healthcare practices and work on our own biases.
You are now listening to CJSW 90.9 FM, broadcasting out of Calgary, Alberta, at the University of Calgary campus radio station located on Treaty 7 land. So before we begin, I want to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, the Piikani, and the Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including the Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home to Métis Nation of Alberta, District 5 and 6. I would also like to note that the University of Calgary is situated on land adjacent to where the Bow River meets the Elbow River, and the traditional Blackfoot name of this place is Mohkinstsis, which is now the city of Calgary.
Today, we have a special guest, Dr. Cheryl Barnabe, who is a Métis rheumatologist. And with that, I'll let her introduce herself.
Okay, well, hi, everyone. So I'm a member of the Métis Nation of Alberta, although now we are called the Ottawa-Pimissawak Métis government. And my family roots are from the Red River Valley, and that's where I was raised, and came to Calgary in 2006 for training and stayed. And my research life is health services research, and as a clinician, I'm a rheumatologist. So I see people with things like rheumatoid arthritis and lupus. So we're one of the internal medicine subspecialties. So we don't do surgeries. So we're part of the medical specialists. And we primarily work on diagnosing and treating autoimmune diseases that affect the bones or the joints or the connective tissues. And we use medications to control abnormal inflammation that's occurring in people's systems. And it leads to, if you have uncontrolled inflammation in those tissues and joints, it leads to joint damage and destruction. And that's what leaves people with disability over time. So we try to prevent that.
And what kind of got you into the journey of specializing in rheumatology?
I definitely set out to be a rural family physician. That's what I knew. And that's what seemed, you could see a diversity of different conditions and have patients from all sorts of different age ranges. But when I was going through my training, there was the opportunity at the time to do a rural elective for 4 months between Med 1 and Med 2. And so I signed up for that. And about a month before they canceled, a month before I was supposed to start, they actually canceled that elective option just because the program wasn't actually training more people to become rural family medicine specialists. They would actually do really well in their clinical rotations, and then a subspecialty group would say, hey, why don't you come and work with us? So I ended up having to do a research project instead. And I say have to because it was definitely not on my planned career list at all. But through that research project, I got to work with a variety of different residents and met someone who was really inspirational. And because she was a specialist, I thought that I should do that too, because she had, so much enthusiasm for her work, and certainly, even though it was more years of training, had a great knowledge. Mm-hmm. And so I thought I'd pursue specialty training instead. Mm-hmm. And I was initially actually really, really interested in dermatology, but at the time there was only about 4 spots in Canada available. So I had a backup of doing internal medicine, and rheumatology had been one of the electives I did in training. I thought I'd see lots of different skin conditions, but realized that I was really enjoying rheumatology as well. And of course, this was all at about the same time that biologics were coming to be available to practice. And so we now didn't just treat patients with steroids and, assistive devices for them to mobilize. We actually had medications that completely changed lives. So people now had lots of control of their disease. They didn't go on to get the horrible damage. They didn't need to be in hospitals anymore. All of this shifted to outpatient medicine. So I think it was a nice combination of still having a lot of general knowledge that you need to apply in your practice, but also just that unique ability to make real significant differences in people's disease journeys.
Nice. Okay.
Mm-hmm. And then, do you think that your role did your heritage as like a Métis individual influence your role as a practitioner?
It certainly did. So like many people that are from the Métis community in southern Manitoba, at around the time that my grandmother was young and raising her family, it was extremely shameful to be a half-breed. There was a lot of discrimination. And so your way to survive was actually to assimilate. And so we had an identity of being a French-Canadian family, basically the whole time I was in school, like elementary and junior high and high school. And it was sort of towards the end of high school that our family heritage was brought back to my grandmother. And of course, it was a different time and space by then. And so these were things that we could talk about. And so I, obtained my certificate of status with the Métis or Manitoba Métis Federation. And then I started medical school. And right in those early first few months of medical school, there was a group that had organized that were Indigenous medical students and residents. And the idea was that we would spend time together twice a year to support each other, to do activities on land, support each other as we went through our medical training programs. And so very closely aligned with my journey through medicine was also my journey of that identity and learning, about my family heritage and who I was. And also at those retreats that we would have, we would learn about incorporating different aspects or additional aspects of health and healing and wellness into medicine. And so really all of, the whole thing really interdigitated quite closely together about me becoming a physician while also learning more about my family. And so I think I do have a unique perspective from that. I learned a lot that, medicine isn't just diagnose and treat and give medications. And there's a whole different aspect of it around how people are doing on a day-to-day perspective, how you communicate with people, how you find that initial connection that creates a trusting bond as you're moving ahead with people. And I think it, you're also respecting, because my practice is all situated either on First Nations reserves or at the urban downtown Indigenous clinic in Calgary. I think it really situates that we're all connected. And I still come across people who are actually family members who've relocated to Alberta, and you have more responsibility. I feel that I do a good job and treat people very well. Because of all of that different aspect of that coming together for my personal life and my professional life.
And do you, in your own practice, when you are meeting with patients, how do you like to bring in your own, heritage into your practice and tailor that for your patients?
Yeah, so one of the communication skills that we teach others who are not Indigenous but are working with Indigenous patients or in communities is around finding that piece of connection. And so sometimes I will introduce myself. People want to know where you come from, how it came to be that you're working in their community. So I will talk about my background in that way. I think too, though, it's a different approach where there's less of when I went through medicine, like they teach you that there's professional boundaries. You do not talk about yourself. You do not let anyone know about personal details. And it's not that I'm like openly sharing very private things with people, but it's okay for them to know I have kids, right? They all watched me have my kids early on in my practice, and they know that my kids play different sports. And so there's that sharing that occurs because, again, we're all very connected around the next generation, and making sure that we're supporting each other. And I think that's a key different approach than maybe what my colleagues would normally take in their practices.
Yeah, I agree. I think having that connection with your physician, specialist, whoever it may be, is really important, because it allows you to trust and build that trust. And that trust is such a key factor in any relationship that you do build. And so I agree. Kind of sharing those little tidbits can go a long way.
Mm-hmm. And even adding on to that, I think a lot of the healthcare practices that we see if we go to a clinic or a hospital is very westernized. So that leaves out a large majority of the population, which may practice different things or may have a different approach to healing and medicine in general.
I think we actually did, because the second part of my career was becoming a researcher. So, I've also employed that to understand how my colleagues will ask Indigenous patients about how they use traditional healing practices as part of their arthritis care plan. Or are people comfortable when patients choose to not pursue Western medicines for a period of time because they're using ones from their own community or their own knowledge base? And certainly many rheumatologists are, I think people are open, like, if they're doing ceremony and that, is good for symptom management, then I don't have an issue with it. Or there's a rub going on, I don't have an issue with it. But people get very, very nervous when it comes to other aspects of healing that might require ingestion of different things. And they're worried that it's going to interact with medications, or, we're very, very primed in rheumatology to treat to target and be aggressive, and medications are the only pathway forward. And I think that has to be drastically different when working in communities where there's times when people aren't comfortable with the options, because after all, most of the patients from Indigenous communities have never been involved in the clinical trials that show that these medications can work. So maybe they don't work as well, but we assume they do as a Western practitioner, or people are working through other aspects of their health or their social reality, and following up closely with a rheumatologist is not what is possible for them at that time. And that makes my colleagues very nervous, and they're, very worried. And I think it's something that we have to address and understand is coming from a place where people are doing the best they can, and we have to be willing to accept that.
Yeah. Recently in my job, we kind of talked about health equity and what that looks like. And we kind of had this conversation about, is health equity surrounding population fairness or equitable health outcomes, and what does that look like? And I thought it was very interesting, because when we talk about health equity, we assume population fairness in it, but it's hard to have population fairness when there's so many other factors. And so, like you were mentioning, just having different practices that kind of align with different cultural understandings. What is your perspective using that on health equity, and how we can kind of advance it in our practices, knowing that Western ways are sometimes the ways that everyone agrees is the right way?
Yeah, well, I think so definitely people are starting from a different place. And so just providing exactly the same to everybody, which would be what is equal, is not going to get the same outcome, because people are starting from different places or have different realities as you go through that journey with them. So one of the most demonstrable ways that I've seen that was actually to look at early inflammatory arthritis outcomes using a Canadian cohort called CATCH. And so in CATCH, what we did was examine people who self-identified as having Indigenous identity or Indigenous membership. I used identity twice in a sentence, so you can correct me on that one there. So they were self-identified as being members of the Indigenous community, and they were all starting off at the same disease place. So the number of tender and swollen joints were the same to the non-Indigenous members of the cohort. People were being seen within a year of their symptom onset, which is still a really long time, but is a benchmark that means that they're getting access early enough in the disease process to change it. Also, the things that were the same was that people were all getting the highest level of early inflammatory arthritis care we can provide in Canada. And that's having high volume centers who are engaged in research, who are taking up the evidence-based practices that we have. And we also adjusted for all the things that we know inform how you do with your rheumatoid arthritis over time. So we literally are trying to take the best case scenario and comparing how Indigenous patients will do in that first initial couple of years of RA compared to non-Indigenous patients. Mm-hmm. And so where everything's exactly the same, we still see a disparity of 60% lower odds of being in remission at year 3 compared to, for Indigenous people compared to non-Indigenous. So we're doing equal things, right? We're doing things exactly the same. We're treating people off, starting people off at the exact same treatment place. And yet we're seeing a huge gap that occurs in those first initial years. And so we know that we need to do something different. We need to do something better so that remission rate is the same between the population groups. That's what we're really aiming for, is the same outcome.
Right. That's a really huge gap. And that makes me wonder, what are these kind of differences? Are there any accessibility barriers, or why is there such a big gap?
Yeah. Well, and that's the question, right? Is it because, there's other determinants of health that we don't adjust for in our models? So things that aren't readily measured, is it because of people's trauma that they've had and they're trying to overcome? Is it related to maybe the medications don't work as well in Indigenous patients as they would in non-Indigenous, but we don't know because they're not recruited to the clinical trials that inform the drugs that are approved? Is it something about the nature of the relationship with your provider, or how connected you are to your culture as a protective factor, for example? So I think there's a lot of questions out there, and maybe some of the solutions aren't going to come from the health system. And I propose that probably the solutions won't come from the healthcare system. The solutions are going to come from those protective factors that help keep people well and are increasing their ability to be resilient as well.
Yeah. And I feel like the factors that you have mentioned, they're hard to control for. You can't control, technically it's very hard to control for them in research. How do you control for someone's trauma? Everyone's trauma is different. The way they deal with it, experience it, you can't control for those things. So it becomes even harder to understand why there is such a big gap and what we can do. And obviously not one size fits all. So for people, one way will work, for someone else, another way would work. And I find that's the hard part about reaching health equity, is that it's so multifaceted that you can take any approach, and sometimes it's not even the approach. There's just so many different approaches.
Yeah, you're exactly right. And I think that's where, because clinicians want to be standardized and they don't want to be accused of bias, and so they're also afraid to take the extra steps, or they're not given the resources or the time, or are working in a place where those resources can be accessed. And it kind of looks like a massive mountain. How am I going to change things for each individual with each individual set of realities? And so I think that's where the base is creating that trust with someone, especially in a chronic disease that's longitudinal. You have to really be able to work with your patients and hear them and listen to them, and then take the actions of the things that you can, and not just be paralyzed by like I can't fix these things, so I'm not going to try. I'm going to default back to my biomedicine approach, right?
Yeah.
So,
yeah, like there's some systemic things that you can't change for sure. It's harder for one person to change it all, but there are things you can do in your practice that can change something. And I think the biggest thing for me, just hearing from speakers who have come on, trying to do my own research and reflection, and I think that trust building is so essential for vulnerable populations, underserved populations, that it goes beyond like having that relationship with your family physician or whoever it may be, allows you to actually really take control of your own health too. It's empowering on your side.
And I think as both of us, Harveen and I, both want to go into medical school and be a doctor. So for us, we're also trying to learn about how can we be a better practitioner? How can we help the communities that we hope to serve one day? So this is all like really helpful for both of us. And as doctors, we want to build a really strong relationship with our patients, but also balance some of these standardized rules and regulations that we have to adhere to.
Right.
Yeah, and I think it's tough. It's tough. You're sometimes put in these boxes where it's hard to step out because that is the standardized way. There's certain guidelines you have to meet, but then there's times where you want to do more, but stuff restricts you, rules restrict you, regulations restrict you. And that's the part where it's really tough. And you see it a lot nowadays where it's becoming harder to speak out, or it's becoming harder to really be there and provide that good quality care. And it's not just rules and regulations, it's also funding. And I think funding and resources are so key. And without them, it's very hard to even do anything. Like currently, I'm working in a public health department and I'm working on a project, and project seems very, it makes sense. But once you start doing research into it, you realize just to do one little thing in public health, there's a lot of steps that you have to take, a lot of research that you have to do, justifications for why you are doing the things you're doing. Are you doing it ethically? Are you doing it evidence-based? And just those little nitty-gritty things take a lot of human resources. And with that, there's time constraints, there's budget constraints. So it can become very tough. Healthcare can be very tough.
Yeah. Well, and getting a new way of doing things into an operational budget, that doesn't lie with the physician's right control. Like that's a health system decision, and policy, right? Who's going to get funding for which medications? That's decided at the provincial, or if you're with First Nations with treaty status or Inuit, then it's at the federal level. So, those are really difficult, hurdles to overcome. But that's where, the advocacy piece of becoming a physician is really critical. So you might, start out with having advocacy for the individual patient you're taking care of on the ward, or picking up the phone and advocating to a company to give compassionate medication to a patient who can't afford health insurance premiums and yet needs a medication that's expensive. And I think there's people who are appropriately in medical leadership positions where their role is to influence policy and create the evidence to change policy over time. So there are many different levels for you both to act on down the road.
Hopefully one day.
Yeah.
I was going to ask, so you're both a researcher and a clinician, and you've had your own research program, the Arthritis Care for Indigenous Populations. So I guess when you find some things in your work, how do you kind of reconcile with your role as a clinician?
Yeah, I think the beauty of it is to actually see those both sides. So I find many of my research questions are driven by what I'm seeing in clinic. And I would say the same thing for other clinician researchers. I mean, you're encountering a problem on the ward and you just keep seeing the same thing over and over again. And how can we make it better? How do we understand why it's happening? So I think there's that natural piece where your curiosity as a researcher, or what you decide to work on, works best there.
Right.
And so I think, the things that we've been able to do. So within the program, first, it was just about describing the epidemiology of arthritis in First Nations people of Alberta. It was around describing care disparities and different outcomes that we see through exposure to different medications or, in different care models and such. And so there was that piece of understanding first, what are the differences that we see? And then the next piece was interviewing patients and talking to clinicians and other types of providers to say, why do these differences exist? What are the barriers to getting access to care? What are the things that we could do to make it better? So that took a lot of qualitative work to be able to get to that, because you can't just get to it from a survey or, looking at a database. You need to actually talk to people in that. And then closing the gaps and finding interventions to close those gaps. Part of it's coming from Western knowledge about effective models of care or how we organize the health system, but also working with community and working in patient-engaged research or patient-oriented research, and working with the community to say, okay, here's an idea, but how do we contextualize it to the reality of this community? What are the things that seem to work best for you? And then once we develop what this looks like, how do we measure it and evaluate it to make sure that it's actually closed the gap from biomedical perspective, because we need to prove with outcomes and with money to get things funded going ahead, but also from that patient experience perspective or community experience. What are the things that were really of importance to you? Was it around the connection to others who have arthritis in your community? Is it around having that personal touch with someone who's from your community who can come and visit you and support you and help you with your goal setting? And then how do we work together to get that, model that works into place for everyone and spread it out and scale it to other communities? How are we going to do that? So that's what the program has been about, is really first defining the problems. Why are they there? What can we do to close them? How do we measure what we've done to see if they have closed it or not? And what's the next thing we're going to tackle? What's the next challenge that's still there? Just to try to remove as many of those barriers as we can and put in as many facilitators into place as possible.
Right. And when you're involving communities, I'm sure every community is different. So how do you go about kind of involving the local community? And then also, is there a room for Indigenous healers or holistic wellness, or how does that process work?
Yeah, so certainly every community is different with the resources that they have and whether there is someone that is a connection to community for them. Mm-hmm. So in on-reserve communities, there's a legacy of community health reps. So they are people who work within the health system and they do this facilitation. So if someone needs some extra teaching or some extra support, that person is there. And some of these will have, they don't necessarily have elders that are employed by the health service, but people know who the community elders are. And sometimes people just need to have that connection to an elder made for them if they've been disconnected from their community, for example. In other places, it might be that, yes, like in Alberta Health Services, there are elders. We're not allowed to call them elders by the health system. They're traditional wellness counselors, I think. But they're employed and they can travel around to the different hospitals in the city to support other members. So yeah, first piece is connecting with the local community to understand, and that might be the medical leadership of the community or the band council, or in an urban setting, it might be the Alberta Health Services Indigenous Wellness Corps. Finding out who you talk to understand what's available to you. But then our research has worked very closely with people who are patients in the community with different forms of arthritis. And they have the lived experience. They know what it's like to go day by day with their condition and what they're facing. And so we work with them and bring them in as members of the team. And they are there to tell us what to do and to advise us. And they do everything from telling us who we should hire for a certain role, what are the outcomes that we want to collect, and we're accountable to them throughout that whole process. So We're there to report to them on how we're doing in our research, how many people have been enrolled, what are the outcomes we're seeing, how do we interpret the data that we have. So it's working with an advice, and I don't love the term advisory because someone can give you advice and you can take it or leave it, right? In this case, we're not leaving it. We are being directed by the community members of how they want things to be. And it's our job to uphold that and follow it.
Mm-hmm. And it seems like a pretty large scale project. So just curious, how long has it been running for?
Yeah, different pieces of the project happen over time. We are currently, I don't know, I've been working with the communities probably for about 14 years now or something like that. And there are some, and the other part of the autonomy is that there are some projects that some communities don't want to be a part of. That's totally fair. We still deliver care in the best way we can. Other communities want to keep pushing the dial to get to better places. And so they're very engaged. Right now, one of the projects that we have running is to look at shared decision-making for treatment choices. And that's because in rheumatology, we're so lucky. We have so many different choices now for medication options. And so it's actually confusing because there are so many options and many complicated aspects about why you would choose one over the other. So is it because of the amount of benefit that you might have from one choice over the other, different risks for side effects, different ways in which the medication is delivered. So some people don't like injections, some people don't like pills, some people have risk profiles that make it that you want to have shorter time on drug exposure before it wears off. Other people have lifestyles that they go away for months at a time, and so you need to find a way to treat that is in a way that works for them as well. And so we're bringing all of that into what we call a decision aid, which is putting all the information down into a format for people to talk through and read through. But we're also putting that together with decision coaching, which is where you actually have someone who is there to help make that. Like, they're not there to tell you what to do. They're there to help give you the information to make your choice, and bring up again, like, is this aligned with your values? Is this aligned with your preferences? So we're testing that right now to see if we can improve the confidence that people have in their decision, because they've been able to actually have a chance to digest the information and ask all the questions that they need to before they make a choice.
The program seems very empowering on the patient side to be able to make decisions for whatever suits their needs the best. And I think that's very helpful when it comes to patients deciding what is best for their own health, because they know what's best for their own health. And so I think I really enjoy just research projects that really work with community, because I think it's very, very important to work with community. So got me really excited hearing about the project. Thank you for sharing.
Yeah. And I know, like, some people are very resistant to the idea of empowerment because it means that, I'm choosing to give how much power I'm going to give to you, right?
Yeah.
And so I think more of it as balancing the roles, right? So we're trying to really get away from that authoritative physician who tells you what to do to, I'm here as a helper, and here are the things I know. I don't know everything, but the things that I can help you with, that's what my role is, right?
Yeah.
Ultimately, it's them who have to make that decision every time that they're going to take an RA treatment, right? Every injection, every tablet, everything like that. It's got to be something that you're comfortable with doing yourself, right? So I can't make that call for someone. I don't know what they prefer. So
Yeah, I was going to say that's great that we're starting to take some of these steps to build like better connections with these patients. But is there anything else that physicians can do to create a culturally safe environment for Indigenous patients? For instance, you are of Indigenous heritage, so it might be easier for patients to build that bond, but do you see the difficulty, for instance, if there was like a non-Indigenous clinician with a patient? how could they take steps to create a safer environment?
Yeah, it's interesting because I think there is that connection with someone from your own community that does make it easier. I do honestly believe that. Mm-hmm. I think it's more about the time that is given to people and really being engaged in that moment with them. So I think where people get upset is if they feel like they're rushed, or they're not being listened to, or you're distracted, or you're just there to kind of push them through. I think that's where I see a lot of and then of course, like if people make racist comments, and sometimes it's not even the physician who makes it, it would be like the front office staff or another patient in the waiting room. Mm-hmm. And all of those things, like, again, it's really hard to control the behavior and actions of others. So your best ability is to control what you do yourself. So some of it is around body language. So sitting down, not standing at the doorway. We don't wear white coats when I go to practice, because that's like another sign of authority. So, I try to be more casual, really listening to what people are giving in their answers. And, we all have the time crunch. We know other people are in the waiting room, but giving people that full on attention as much as they need it is really, really critical to building that trust with them. Sometimes language can be difficult. So how you ask people questions about what they do in their lives, you need to explain why you're asking invasive questions about their personal lifestyle choices, right? Why is that important? Well, it might be because I'm looking for clues about what type of arthritis you have based on some of the things that you do or are involved in, right? But if people understand that that's what you're doing and why you're asking, that helps. So I think that's the best advice I can give to anyone going into practice. It doesn't matter if you're working within or outside of your own culture. It's about giving people that attention and being human. It's really about being human. So,
yeah. And kind of to just kind of end the kind of podcast off is, why is arthritis care important for Indigenous populations?
Yeah. So
any questions?
Yeah, that's maybe we should have started there. Yeah. So one is the prevalence. So how many people in the population that are affected by it is so high. Like, it is just so high, and it doesn't matter how we determine the prevalence, like whether it's by us doing self-reported surveys, whether it's by going into community and identifying cases and determining how many people in the population are at risk and how many people actually have it, whether we use large administrative databases. No matter which way you look at it, arthritis affects 2 to 3 times more Indigenous people than it does non-Indigenous. So one is just the sheer volume. 2, it's around the burden of arthritis. It causes pain. It causes you to lose your ability to do your roles in your community. It takes away, it causes you fatigue. It takes away your mental space for focus and attention. There's so many negatives to having arthritis. Your mobility obviously is a huge factor. And we know that burden is also much higher in Indigenous patients for a lot of the reasons that we spoke about today. So access to care, access to treatment, how things are followed through on or not. Those are all pieces. But I think from the population perspective, we know that arthritis is a chronic disease. So this isn't something that you have for a short period of time and then it's over and you can move on. This is something that affects people for their entire lives, and it will also affect them at a much younger age if they're Indigenous or not. So there's just such a massive burden, and rheumatology has done a very poor job historically, especially when it comes to research. That's been quite harmful to communities. I hear a lot of reports of racism that people continue to encounter, and we have a long reconciliation ahead of us in our profession because of how poorly we've done over the course of hundreds of years. So we have a big responsibility to make it better.
Yeah, no, like one thing I remember a speaker actually spoke about is how data and how when we use that data, we phrase our results and our discussion, put out recommendations, they can be very stigmatizing to specific communities. So you have to be very careful with when you are using data, how are you kind of writing that data? Like, how are you writing those findings? How are you communicating those findings? Are you communicating them in a way that's actually destigmatizing, stigmatizing community? Is it helping people? Is it culturally sensitive? And I think all those things we need to ask ourselves that when we are doing research, and those things are very tough sometimes to even tackle, into seeing how are we going to do knowledge translation the right way. And I think knowledge translation is such an important piece as well. And it's something that I feel like in research, it gets very lost at times.
It can. I mean, you focus on getting the work done, writing up the paper, and that longitudinal commitment to a community when they engage in research with you, that commitment never goes away. So we definitely, absolutely need to. Sorry, I just lost my train of thought.
Okay.
But yeah, we absolutely need to overcome that and do a better job.
Yeah, I agree.
And when you mention reconciliation, what does this word mean to yourself, and how does it reflect through your research, through your clinic with your patients?
Yeah, it's around admitting the harms that have been done. And even though I'm from one of the Indigenous communities, I still also represent the medical community, right? So I'm still there on behalf of all the people that have suffered by healthcare before. I still have to make it better. It looks like practicing in a different way. It looks like advocating stronger. It's around educating my colleagues so that they practice in a better way. And then when I'm engaged in research, it's always about making it better for a community or for an individual patient, whatever the topic is, right? It's not about the benefit of just, getting attention and getting my paper out. It's actually about what is the change that's being made in the community because of what I'm doing or leading. And then it's also about that whole process. It's not just, I got approval to start the project, now I'm off and I don't need to check in with anybody or be accountable to anybody. It's, you got to follow through, and it's a long commitment. So it's not for 6 months, I'm going to do this. You're there as a resource for the rest of time. That's how I see it.
Like when we were talking about research, I find that it's really important to even maintain contact and that relationship post-research. You can't just, connect with a community, work with that community for an X period of time, and then when results and everything is ending, you walk away from the community. That's also not fair, and it's not acknowledging the community and them being able to give you knowledge, provide that data. And again, we come back to the topic of Indigenous data sovereignty. Like and who owns that data? Is that data being used respectfully and in the right way? And I think those questions we all need to ask ourselves as researchers who maybe don't do, let's say, PhD level type research, but even when we are in little projects, I think it's important to reflect on that piece.
Absolutely. And there are times when we've done something and the community gets the report and, I ask, can we write this up now? And they're like, no, I think this is for our internal purposes. Thank you. And that's what you have to accept. That's the conditions. So,
yeah. And so one last question before we wrap up the episode for today. Thank you so much for joining us. This is our first online, fully virtual podcast recording. So the last question for you is, if you could leave the listeners with one point or learning or a highlight, what would that be? take a minute, think about
it. Yeah. You know what? Just treat every person with respect. I think that's the crux of it. Be human and work from the heart. I think that's a really, really critical thing to do. And you can lose your heart when you're sort of being challenged by rules, regulations, time schedules, fatigue, all of those things. But you have to always find a way to come back to what is it you're doing and why, and do it from a place of love and respect for others.
Yeah, I really like the way you put that, work from the heart. I think more people need to do that or come back to it more often when they are in their practice work day to day. But yeah, thank you so much, Dr. Cheryl Barnabe, for joining us today and sharing your insights. This conversation was really eye-opening. It's nice connecting with people with different backgrounds. It's the first time we spoke to someone who does research and who is a working clinician in rheumatology. So thank you so much. Really enjoyed the discussion, and we appreciate you taking the time out of your busy schedule.
Thank you all very much. Take care.
We want to thank CJSW, the Indigenous Global and Local Health Office, Grandmother's Lounge at the Faculty of Social Work, the UCreate team, and our editor, Atia, for helping us with this podcast.
And lastly, thank you to everyone who tuned in. To listen to the full episode, tune into Apple Music, Spotify, or cjsw.com with special guests. And keep a lookout for the next episode. And until then, enjoy the sun.